Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week, we talked to Dr. Sunanda Kane. Dr. Kane is a professor of medicine at the Mayo Clinic in Rochester, Minnesota. She's also the assistant chair of patient experience in the gastroenterology and hepatology division there. We talk about how her parents were convinced she was destined to be a gastroenterologist. We talk about the books that she's authored for patients living with inflammatory bowel disease. We talk a lot about women in IBD, including fertility, pregnancy, and sexuality. We talk about fistulizing, Crohn's disease, and we talk about one of her many fun facts. Cheers!
Hello, everyone. This is your host, Robin.
And this is your other host, Alicia, and we are delighted to be joined by Dr. Sunanda Kane. Did I say your name correctly?
You did. Good for you.
Yes. High fives to me. We are so excited to have you come join us. You are at the Mayo Clinic, which is not far from me, and of course is such a gold standard of care. So we're really happy to have you join us. But we start out in a very unacademic way and say, what are you drinking?
Oh, sure. So I'm still in the office. It is still before 5 o'clock, even though it is 5 o'clock somewhere. And so I am drinking some ginger ale that is made from real ginger. And as we know, ginger has a lot of properties that help the digestive tract. Particularly, this is what I recommend to my pregnant patients for their nausea. And it's caffeine free, so I won't be overstimulated during this conversation. So it's ginger ale for right now. It's also got real sugar as opposed to high fructose corn syrup, because that is something else that is man-made and bad for you. And also, if it were sugar-free, it would have all sorts of artificial sweeteners, which are also bad for you. So real sugar, real ginger, and there you go.
Fantastic. Robin, what about you?
I am switching things up tonight, and I have a vodka cranberry with a little splash of lime.
Ooh.
100% cranberry juice, not made from concentrate. I did not crush the cranberries myself, but I did check. It is 100% cranberry.
I grew them in my bog in my backyard. I am drinking a cider from one of the local cideries up in Minneapolis. And so, Dr. Kane, if you come up, you're welcome to come join me here. Number 12 cidery. So I'm very excited. I was going to make myself a cocktail, but my very elderly dog, who has decided he needed much more attention than I anticipated, so I didn't get a chance to do that. But Dr. Kane, what I really, really want to ask you right now is, why are some people not able to taste ginger the right way? Like, my sister-in-law thinks that ginger tastes like soap. And the same thing happens with some people in cilantro. Why is that?
Oh, that's really interesting. And it has to do with how their taste buds interact with their brain and the interpretation of the chemicals in those entities. So the whole science of taste is fascinating, and that it's likely that all of us literally taste the same thing, but our brain interprets it as yum or ick or yeah, whatever.
Huh.
So, because I do not like cilantro at all. And that's like the hot herb right now, right? And everything's got cilantro on it. And ginger, the other thing about ginger, though, specifically, well, cilantro, there's Mexican cilantro, there's different strains of it. So depending on, there's Indian cilantro. And so the different species have different strengths of some of those chemicals. Ginger, if you have fresh ginger root, that's going to be the strongest taste. And obviously that's going to be where the most amount of whatever entities are in there that actually helps with your digestive symptoms are going to be. But you can get the dumbed down ginger tea. There's ginger gum, there's ginger ale. So that if somebody is sensitive to any kind of ginger, then it's just their brain really doesn't like the chemicals in ginger.
So weird. What's interesting is it's only real ginger. Like, if it's the ginger ale that has like ginger flavor to it, she can drink that. That's fine. She tastes
But because it doesn't have the actual, then it's not actually good for you, because it's the real ginger that has whatever chemicals in it that actually help you.
Well, sorry, that was a real off the wall question. I didn't anticipate asking you that. It just sort of came into my brain. But let's get into the real conversation here now. We always like to ask our professional guests, why did you choose inflammatory bowel disease disease. So when you were going through medical school, what triggered it so that you were like, yes, I want to be a gastroenterologist and I want to study IBD?
So from a very young age, actually, and my parents used to tease me and say, she's going to be a poo doctor, because diarrhea has always fascinated me. And that is like, my husband rolls his eyes whenever I get asked this question at a cocktail party or a reception where he's at, but it's true. Diarrhea fascinates me. And then when I was in college, I worked for an infectious disease specialist in his lab trying to find the bug that caused Crohn's disease. And we obviously didn't find it, but that's what, as an undergrad, even got me to know anything about Crohn's disease. So that was my research that I had to do if I was interested in going to medical school. I didn't get into medical school the first time I tried, and I ended up working as a research assistant for Dr. Stephen Hanauer, who is one of the godfathers and grandfathers of inflammatory bowel disease. And I was his research assistant, and the fact that I knew how to spell Crohn's disease and sort of knew what it was, that's how I got the job. And then I got to actually meet patients with ulcerative colitis and Crohn's. And I was just, I was fascinated by the whole disease. And then I felt so bad for them because they had such horrible quality of life. And this was something that I just really wanted to do, was establish relationships long-term with patients that I thought I could help. And so after 3 years of working with Dr. Hanauer as his research assistant is when I reapplied to medical school, and I got in and knew that's what I wanted to do after medical school, was go into internal medicine and then go into GI and then go into IBD and be an IBDologist. And here I am.
That is amazing. I love that so much, that you were fascinated by diarrhea as a small child. It's definitely a unique take on it. Definitely a unique take. And as a patient with IBD for 20 years, I thank you.
Yeah. So lots of things cause diarrhea, right? So you actually have to put your thinking cap on, and because there's lots of organs in the digestive system that are involved and have to be healthy in order to have a solid bowel movement, and that there are other things that you can put in your mouth that will give you diarrhea even when all of the system is working correctly. So I really enjoy what I do.
It is obvious. Yes. It's always nice when we talk to professionals, because the way you talk about it, you can tell that it's something you find so interesting and are really passionate about. So this is why we love interviewing doctors and healthcare professionals, because we've only ever encountered people that seem to absolutely love diarrhea and love to work in this field. So we love that. You have a special interest in women in particular, and in fact, just published a book. Congratulations. We have not read it yet, but I think we will. So we want to take you down that path, if you don't mind. I know that there's lots else we could talk about, but we're going to talk kind of women specifically, if that's okay.
Yeah.
Great.
So I will tell you that this is actually not my first book. So I think the book that you're talking about is specific to women's issues in IBD. And I co-edited it with Dr. Abraham and Dr. Glassner. But I'm more proud of the book that I authored that's written for patients. On self-management of IBD. And we are now in its third edition, and that's coming out hopefully in September.
Oh, that's fantastic. Yes, I would love to know more about that one. Talk to us about that one first, and then we'll talk to you about the other one.
So we have several gastroenterology societies, and one of the bigger ones, the American Gastroenterological Association, which is a handful or a mouthful, approached me and said, hey, Dr. Kane, we have our own press and series of books, and we would love for you to author a book on IBD specifically for patients. And I said, wow, why me? And they said, why not you? And so I gave up a year's worth of any free time that I had, and I wrote a book. And my editor said, I want you to just sit down and type what you would say to a patient about all of these different things. So what is Crohn's disease? What is ulcerative colitis? How did I get this? What meds should I be on? What should I eat? What about surgery? What about pregnancy? What about if my kid has it? What do I do when I want to travel? So I think 13 chapters, and edition 1 came out, in I think I was still living in Chicago. So this would have been like 2005 maybe, was my first edition. And it was so popular that 3 years later, I was asked to write edition 2. And I did that, and it continued to be the best-selling book of the AGA press. That's my claim to fame. I am no James Patterson. I made maybe $27 total on book sales from those two. But if you go on Amazon right now and try to buy one of the last existing copies of the second version of my book, it's selling for like $4,000. I kid you not. It's like hysterical. My secretary just laughs. So when it came time for version 3, because my version 2, I think, is from 2009 or 10. And oh my goodness, think of all the things that have happened in the last decade in terms of medications and science and the like, that clearly we were due for another edition. But, all of my spare time, didn't necessarily know when I was going to do this. And the AGA shut down their press. So I no longer had a publisher. So then it was like, okay, well, now I'm going to have to go out and shop for a publisher, and I just don't have time for that. And so I just let it drop. And then one of my colleagues suggested, I will help you write the next version. And why don't we make it from the Mayo Clinic press? And so Mayo Clinic Press said, yeah, we don't have a book on this already. We'll publish it. And so I've been working with one of my colleagues who is down in Florida, and the 3rd edition will come out in probably September. Now it would be published by the Mayo Clinic as opposed to the AGA.
Very good. I'm excited for that book to come out.
Yes,
yeah.
me too.
So it's written for patients.
That's awesome.
It is not written, but providers can read it. It's really in English as opposed to medical.
Yeah, that's invaluable.
Yeah,
I'm definitely marking my calendar to read this book. To
Okay.
buy this book and read it. Yes.
Yeah, that's really invaluable. You mentioned one of your chapters was on pregnancy. And so the very first question I wrote down was, can you tell us in short amount of time, which this may be a long one, is why does IBD affect fertility in pregnancy? I know, I'm sorry. That's like, here's a giant topic.
Okay, let's just go back a minute, because you had asked something else. You had alluded to something else, and I wanted to make sure I got back to it, which was, we were talking about how I got into this. And I just want to reflect back, because I told you how I got into IBD, but another big part of that is that when I was a GI fellow, there were just a handful of women in advanced IBD care in the academic centers.
Really?
And so I was being trained by men. There were no women that I could look up to. There are a few who are a few years older than me now, but not in the Chicago area. So I did look to them. But honestly, the vast, vast majority of all the IBD specialists back in the mid-90s were men. And so when I would walk in to see a female patient, the female patients loved it that they could talk to a woman who was going to listen and understand some of their specific issues. Specifically, so I have a master's degree in biostatistics and epidemiology, and my master's thesis was on the effect of birth control pills on IBD. And one of my first publications was on the effect of the menstrual cycle on IBD symptoms. And that for years, women were telling me that they would always feel worse around the time of their period. And that when they tried to tell their male physician that, they would be like, yeah, okay, whatever, or yeah, and then like either not acknowledge it or not really know what to do with that. And it was frustrating to a lot of women. And so the more I heard it and was communicating with my male mentors, they're like, no, we've never heard that. And I'm like, but it's true. It's a phenomenon. And so I studied it and showed that this was a real thing, and that helped actually change how women get interviewed and how maybe they even get treated based on their menstrual cycle. So I'm very proud to have been one of the founding mothers in academic IBD.
Wow, that's awesome. We were silently applauding you, because that is a remarkable achievement, and it's incredible to think that wasn't thought of before, but maybe not so incredible to think about.
It's not incredible to think that. I mean, I could say that's 20 years of living with IBD until I decided look, we've had a lot of great male doctors on the show, but I prefer and will probably always see a female IBD doctor. I started seeing a female IBD doctor in 2018, and I won't go back to a man. Sorry, guys. It's just different. It's just
It's
different.
different, right? And you know, it's definitely one of those things where I love my male colleagues, and I actually had one of my male colleagues do my, colonoscopy when I turned 50. Okay, so now you even know that I'm over 50. But I get it that there are very intimate issues that you're going to already be embarrassed to talk about, and that having a woman to talk about it, that maybe it's a little bit easy. And so there you have it. So you were asking me, what was it about pregnancy and fertility that you were asking? Sorry.
Why does IBD affect it? So again, a nice simple question for you.
Okay. Well, so any chronic disease is going to have a potential effect on the ease on which you get pregnant and then potentially being pregnant. So being pregnant is actually a pathologic state, meaning that it's not normal. It's natural, but it's not normal, because you usually, it's not normal that you are pregnant all the time, right? Unless you've had 18 kids, then you're pregnant most of the time, but that's not most of us. So that a chronic illness or condition is going to have some effect on either how your organs are functioning or on the hormonal changes in milieu that is occurring, or the kinds of medications that you may not be able to be on because you're pregnant, in treating that underlying condition. So with inflammatory bowel disease, which is thought to really be an autoimmune condition where there is an overabundance of immune activity against something that we haven't identified, that when you are pregnant, you have to be in an immune suppressed state. And why is that? Because you have a foreign body growing in you. And if your immune system is revved up and recognizes this foreign body as foreign and like, hey, this doesn't belong here, out it goes, that's what we call a miscarriage, right? So we don't want women to miscarry these foreign objects that they are carrying inside of them. So we have to naturally down regulate our immune systems so that this baby can grow. And so when you do that, you are actually suppressing your own immune system. And so some women with IBD get better because they're suppressing their own immune system and they don't need medications. Having said that, there are other women who will have a suppression of a part of their immune system, but the rest of their immune system is so revved up that they do need therapy and that they are worse off because they're pregnant. So there's a lot of crosstalk and complexity to that question. What we also know, though, for IBD patients in particular, that if you have had surgery, that usually that involves the lower abdomen and the pelvis, and that you are going to have scar tissue. And scar tissue makes it harder for eggs during ovulation to go from the ovaries through a tube into your uterus. And so from that standpoint, it's harder to potentially get pregnant. And so hopefully that answers some of your question.
It does. Yeah. And I guess as you were talking, I was thinking of things that we've heard about from other women that are trying to get pregnant, is that if you calm the inflammation down, so you try to get somebody into a state of being as stable in their disease and have as little disease activity as possible, it increases their chances of being able to get pregnant and stay pregnant, correct?
Right.
Okay.
So what we talk about is for pregnancy is that if a woman at the time of conception is in remission, meaning she has inactive disease, she has no greater risk of having a flare than a patient who is not pregnant. And so the risk of a flare in a 9-month period is somewhere in the range of 10 to 15%. So it's no greater. So you can still flare, but your risk isn't any greater because of the pregnancy. So because we want you to not flare, we have you continue your medicine. For a woman who gets pregnant when she has active disease, we talk about the rule of thirds. A third of women will get better, a third of women will get worse, and a third of women will stay exactly the same. The women who get better often say, hey, I'm in a flare, I'm going to get pregnant because that's when I felt the best. And we do not recommend pregnancy as a treatment for IBD. The women who get worse need very aggressive follow-up and care to the point where you would be giving steroids quicker than you would to somebody else. You might put them in the hospital faster. And then it's really a team effort. You're going to see that patient frequently. They're on a very short leash because it's really important to monitor and make sure that she is gaining weight and that the baby is gaining weight if there's active disease.
So you mentioned staying on medications. I'm sorry, Robin, I just interrupted you probably, but that brings up that there was a big study just recently about disease modifying medications and how what, if anything, do they do for folks who are pregnant? And luckily the studies were pretty conclusive that many of the medications that are available to women seem to be okay. Is that right?
Right. You might be referring to the piano study?
The piano study, yep.
Yeah. So I'm very proud to have been one of the founding members of that study. I've been involved with it since, no pun intended, since its inception. And that, yes, the whole point of the study was to follow women prospectively on their medications to see how they did. And that we have shown in a large number of women, so over 1,200 pregnancies that we followed prospectively, that staying on your medicine helped you not have a flare and resulted in a healthy outcome. And that women who stopped their medicine would flare and would not have as good outcomes. And that the medications that they take do not have an effect on their babies in terms of congenital malformations, otherwise known as birth defects, childhood infection, childhood cancer, need for ICU stay, and the like. So all very encouraging that, look, you treat the mom because the baby is going to do poorly if the mom is doing poorly. So don't say, oh, she's pregnant, we can't give her this. That baby is a parasite and needs mom to be healthy. So you got to treat the mom. So don't practice benign neglect is what I tell my fellows in training.
That baby is a parasite. That's
for 18 years, at least.
Sometimes longer.
I have a 20-year-old and a 23-year-old. I can guarantee it does last longer than 18 years, but I don't consider them a parasite.
Okay.
But there is still assistance necessary when they are in college and applying to things like PA school. I'm just saying. So this is just anecdotally my experience. So I actually think I had a flare. I had active disease after I had my first child, but I didn't know what it was. And I got pregnant again a year later and I felt better. But then as soon as I had Bailey, I started having symptoms again and went downhill pretty quickly. So she actually turned 1 while I was in the hospital having surgery to have my colon removed.
Oh,
and what you just said makes so much sense to me. I mean, but that was 20 plus years ago. So medications weren't what they are now. Options weren't what they are now.
Right.
But I always wondered if my first pregnancy was that environment, was that trigger, that turned on my immune system.
Yep.
And then I got better with the second one. And then after that, like downhill real fast. So that just is, I haven't heard it said the way that you said it before. It's very interesting to me. Now I really feel like that's more than likely what happened. I'm going to totally go down another route because we had a guest that we interviewed last night that talked about perianal disease.
Sure.
And we're talking about pregnancy and that has to do with sexual function and then perianal disease. I mean, I feel like being a woman, perianal disease may hinder your ability to get pregnant also because you're not wanting to be a freak in the sheets. I don't know.
So a third of Crohn's patients have fistulizing disease. So this is not uncommon, and that perianal disease is particularly difficult to treat from many different aspects, which is one, just from a medical standpoint, you're dealing with the anal canal and the rectum, and those are two different organs systems, actually, because they have different types of cells and different functions. And when you disrupt the normal anatomy of both of those things, it can be very hard to fix. Number two is that you're dealing with a very small real area of real estate. And so something that is wrong there is going to cause a lot of symptoms because it's so much of the area that is now deformed or injured or inflamed, whatever word you want to use. And number three is that in a woman who wants to have some sort of social life and sexual life may feel extremely hindered because this is visually disgusting. If she is actively draining stool or pus, who's going to want to be with her? It can obviously cause a lot of pain with receptive intercourse. And so just for those reasons alone, it can be very hard to consider trying to get pregnant. Plus, if you do get pregnant, then you are putting more pressure on your pelvis as that uterus grows. And for sure, you're going to need a C-section because you don't want to disrupt your anal canal even more. So it can be a really big deal for a woman to try to juggle all of those thoughts and feelings. And so there are some tricks that over the years I've learned from my patients, as well as just sort of thought about what makes sense, is that when disease is super, super bad, where there's so much deformity, there's so much drainage, there's so much pain, that sometimes you just need a rest. And a rest away from that is having a diversion ileostomy, so that stool doesn't have to go past that area, and it's allowed to just rest, and it's given a little vacation. Everybody needs a vacation, so do your perianal fistulas. And that can sometimes help with feeling better about trying to engage in receptive intercourse. I always say, well, you know what? It's really romantic to have the lights be really dim or even off. And so sometimes it's just that you have the lights off so that nobody can see what's going on down there. And if it's not uncomfortable or painful to have intercourse, maybe you just need the lights off. And for my patients who actually are stomates, who are concerned about what they look like with a stoma, I recommend looking at some of the websites that sell the lingerie that is meant for sort of alternative lifestyles, and that crotchless underwear and the teddies that are either crotchless or snap, because then if you're covering your abdomen, but you're not covering your genitals, and that those have served very well for some of my patients because they're self-conscious about the stoma as opposed to, what their pelvis looks like. So there are ways to have those frank conversations. I usually try to bring it up because most women won't necessarily bring it up, and I want them to feel like my clinic is a safe space to have those conversations.
That's really wonderful. I'm really glad that you're doing that with your patients, because you're right. I don't think doctors, maybe many of them are not very comfortable talking about it.
Right. Well, that's the other thing, is that how many, so there's a male gastroenterologist that I know. He's a little bit senior to me. And he said, Susie, he goes, do you know why I'm always going to remember you? And I'm like, no, do I want to know? And he said, because you're the only one who has enough guts to talk about crotchless underwear at a medical grand rounds. And I'm like, oh, see, obviously I made an impression. And so it can be really difficult to talk about sexuality and sexual practices, because that's not what we're taught in medical school. Right. And it can be really, and depending on your own cultural beliefs and your own, issues with sexuality, that it can be really hard to talk to somebody else about it. And I mean, it's not that much different than talking about alcohol. I mean, we're not trained to talk about that. And that, the definition of an alcoholic is anybody who drinks more than you. But what if you drink 5 drinks a day? So these are things that are really, really tough to talk about. And other people say, I don't have time, because once you sort of knock on that door, then if the door opens, then suddenly you are overwhelmed with emotion and data that you didn't want or don't know what to do with. And now, this isn't a conversation you can have in 2 minutes. Right. So what I try to do is decide that that's going to be the main agenda point for that visit. We're going to talk about your perianal fistulas and what it's doing to your life, because you are more than just a Crohn's disease diagnosis. You are a person walking around with Crohn's disease. So let's talk about how it's affecting you.
Well, I would imagine patients too sort of make the assumption that you're a gastroenterologist, you're not my OB-GYN. So I'm not going to talk to you about sex because that's this doctor, not this doctor. So bringing that up is really important.
Exactly. And so, So I don't mind if they want to talk to their OB-GYN about that, but their OB-GYN may not understand the nuances of the medications or like the anatomy of their fistulas or the like. So I want to make sure that I'm available to them to have those conversations.
Yeah, no, I think it's really important.
Possible.
And I think, you talk about opening the door. I think a lot of times too, we talk a lot about mental health on our podcast. And I think we see doctors also saying, I don't know that I want to ask the question of like, how are you doing other than your IBD? Because they, like you said, it's not a 2-minute conversation. If somebody's feeling really depressed or anxious or struggling with their mental health, it's a much longer conversation. And so you kind of go, I'll let somebody else do that because I don't have time. Right.
Well, and the other thing too, is that if you don't feel, so I feel like if you do not feel comfortable doing it, at least say, okay, well, guess what? I don't feel comfortable. How about if I send you to somebody who you could have that conversation?
That's really important. That's really important. Like you said, this is part of quality of life.
Right.
And so, having that conversation is super important because it could be affecting a lot of things.
Right. And honestly, so many times that a patient who isn't happy is going to have more pain. They're going to have less ability to engage in their own care. It leads to more phone calls, ER visits. And you say, I have colleagues who say, oh, I don't have time to talk about that stuff. And I'm like, you do, because otherwise you're going to pay for it on the back end when they keep calling the office and you're having to have all of these conversations because you don't even realize that there was some sort of hidden agenda that you didn't know about. And that if you just scratch the surface a little bit and figured out what the root cause of all of this unhappiness is, that you can actually deal with.
I'm going to ask you a question. And so this may come especially out of left field. I had apparently done a little bit of research that I didn't realize I had done because I wrote a quote from you, and it's one of your papers said active small bowel inflammation, extensive resection, or rapid bowel transit may decrease oral contraceptive pill efficacy. Why? And also, does that then generalize to other types of medicines as well? So is it just your oral contraception, or is it also other types of medicines that are less effective?
Yeah. So anything that requires absorption in the small intestine is going to be at risk for altered absorption if you have Crohn's of the small bowel or extensive resection or a fast motility. So not just oral contraceptives, but certain antibiotics, certain other, even vitamins. Patients will tell you that they see their pills whole in their stool, certain and blood pressure medicines and the like. So that it's just that you have to keep in mind, and usually we are not prescribing oral contraceptives. So it's something that is more of a theoretical concept, but depending on the formulation, whether there's it's equal parts progesterone to estrogen, that there is the potential for it to not be as well absorbed as in somebody who doesn't have Crohn's. And it's just something to keep in the back of your mind.
Is that also for folks with J pouches?
Not so much for birth control pills.
Okay. Because that's for your large intestine. Okay. That makes sense.
Right.
All right.
Alicia sent me some information about some research that you're a part of about vulvar Crohn's. Did I say that right? Vulvar?
Vulvar. Yep.
Vulvar. Okay. It just sounds painful and also something I don't want to know more about, but I feel like I need to ask. Is this something that's like super rare? Is it something that you're just discovering that patients are experiencing?
Right. So we needed to write it up because it hadn't been talked about in the literature. And so fortunately, it is rather rare, but that it's something that you need to recognize exists and think about when a patient has non-healing vaginitis or sores, that they are complaining to their OB-GYN or they're going to a dermatologist about.
So, I mean, is it actually Crohn's outside of the colon?
Yep.
Okay.
That is really, really fascinating.
Yes.
So, Dr. Kane, usually the last question we ask folks is to tell us if you had one piece of advice for our community, for our IBD community, what would it be?
Okay. For providers or for patients?
Why don't you do one of each?
Okay. So if I just think about the last 4 hours of my clinic, I saw a patient from Indianapolis. I saw a patient from Utah. I saw a patient from, Indianapolis, Oklahoma City, another from Fargo, North Dakota. So what did these patients all have in common? That they were advocates for their own health and wanted an expert opinion on what to do. And so if you feel like you are not getting the answers or the opportunities that perhaps you think you should be, that advocate for yourself and do what you can to travel to an IBD center. You don't have to necessarily come to Mayo Clinic, but that there are large IBD centers of excellence around the country, and that our job is to try to work with local providers to offer all around care with the best resources available. So, advocate for yourself and do your homework. For providers, that IBD is not cookbook medicine. What the patient can do, what the patient wants to do, what the patient can afford. So when you are considering a management or treatment, think about, it might be the right thing to do in the books, all right, by some algorithm that you look up. But can the patient afford it? Is it the right therapy for your patient in terms of they are needle phobic, or that they live in a place where they have to drive 8 hours for an IV infusion? That you have already thought about what it is that they can do for themselves to treat some of their symptoms. And not all their symptoms are going to be inflammation driven, and that you have to pay just as much attention to that as you do to the active inflammation. And that IBD is not a diagnosis that is made by a blood test alone, nor by what an appearance would be on an X-ray or on a video capsule. You need to have a tissue biopsy to prove chronicity. So I saw a lady yesterday who had a video capsule study, and she has abdominal pain. She doesn't have diarrhea. She doesn't have weight loss. And she was told she had Crohn's disease based on the video capsule. No biopsies have been done. And she has been on prednisone and on infliximab and adalimumab and vedolizumab, and she still has pain. And none of those medicines work. Guess what? She doesn't have Crohn's disease. We did a scope, got up into her small intestine where these ulcers were seen. And oh yeah, by the way, she takes 4 Aleve a day to treat her migraines. This was all NSAID-induced inflammation. So, make sure that you have the right diagnosis before you start giving some of these really expensive and invasive therapies. That's my soapbox.
I enjoy your soapbox.
Yeah.
Thank you.
That's really valuable information for patients and for providers.
Yes.
I'm going to ask one more question that we missed, because on the questionnaire that we sent you, we asked for a fun fact, and you shared
I had a whole bunch of them. I had to choose which one I wanted to put down because I'm a fun person.
I can tell that right away, but Alicia
Absolutely.
and I, you picked the right one for us because we are a comedy duo here on this show.
Got it.
You do stand-up comedy, or you have done stand-up comedy? Do you actively do stand-up comedy? I need to know this.
Right. So a few years ago, I was at a happy hour in a bar that also the upstairs of this bar is a comedy club. And on Thursday nights, they do open mic. And this happened to be a Thursday night. And we were having a happy hour downstairs in the bar area. And for whatever reason, I was just on a roll. I was just coming up with zingers, and I had everybody in stitches. And one of the people at that happy hour said, Susie, you should go upstairs and do open mic. You're hysterical. And I'm like, okay. And I had had enough to drink that this seemed like a really good idea. And so I went upstairs, and all of the people at the happy hour came upstairs too. And you just put your name down that you wanted 5 minutes on stage. And so when my name got called, I went up. And I had written down literally on a napkin all of my best jokes, and I put them sort of in an order so that there was like a theme and so there was a story that I was telling. And the 5 minutes went by really quickly. And how they work for open mic night is that if you get up there, you have to get off the stage when the red light goes on. So if you're not funny, they flash the red light within a minute or two. If you are funny, they will let you have your whole 5 minutes. And so I was given my whole 5 minutes, and people laughed, people clapped. And then when I left the stage, the manager came over and said, hey, if you ever want to come back and do more, we would be happy to have you. So I've gone back several times, and I have done stand-up comedy for our allied health staff when they needed, sort of a pick-me-up during the COVID crisis, when they needed something to laugh at. I've done it for colleagues at different institutions and different society meetings. And yeah, it's definitely something that takes a different kind of skill. You have to have a lot of self-confidence. You have to obviously have timing to deliver a punchline. And for public speaking, you have to be really, again, sure of yourself to get up there and be willing to hear crickets or be booed off stage. So there are photos of me up on stage at certain comedy clubs. There are no videos or TikToks or YouTubes because I will not allow that because, as you know, those sorts of things get around and then people use them for their own purposes. So I do not allow videotaping, but there are still pictures of me. And definitely people will tell you, yes, they've gone to my shows and they really enjoy my comedy.
Oh my gosh, that's so awesome.
I feel like I need to come and stay with you in Minnesota, Alicia, and we need to go see Dr. Kane's stand-up show. Like, I mean, I feel like this needs to happen.
This needs to happen. Rochester's not that far.
It's not. I haven't done a show. Let's see. Well, the last time I did 5 minutes was a couple months ago for some colleagues. And let's see. I mean, one joke that, is always like just off the top of my head is, well, there's depending on the situation, but, and there are ones that are just like really bad puns, so, and I also am a foodie. I like to eat out and the like. So did you hear about the new restaurant on Mars?
No.
No, great food, but no atmosphere. That's a science.
I love it. I love it. Yes, Robin, come up and stay with me, and we'll take a trip down to see Dr. Kane.
This is happening.
So what do you call three rabbits hopping backwards?
I don't know.
A receding hairline.
Oh, my husband will like that one.
Yes. What did the monk order from the hot dog vendor?
No idea.
He wanted to be one with everything. Okay, those are my one-liners. So did you hear about the little kid who swallowed the coins?
No.
There's been no change.
Oh, I like that one.
Let's see, I'm looking through my
Do you keep a special notebook?
I keep them on my phone.
Wow. Sound like an old lady again today, don't I, Robin?
Alicia, please don't tell Dr. Kane to get off your lawn.
Get off my lawn.
Okay. Oh, do you know the Sven and Ole jokes?
Yes.
You know Sven and Ole? Okay,
Robin won't, but I know them, yes.
Okay, so my favorite Sven and Ole joke is that Sven and Ole are just going to get one last ice fishing trip in. So they got their equipment, they've got their auger and their buckets, and they go and they start augering a hole, and there's this big booming voice, "You're not going to find any fish there." And Sven says, "Ole, did you hear that? Was that God?" And Sven's like, "I don't know, but let's move." So they move to another spot, start augering. "You're not going to find any fish there." They're like, "Wow, God, is that you?" "No, it's the ice rink attendant."
I'll explain Sven and Ole to Robin later. It's a very regional
thing. I mean, and maybe that would be, politically incorrect to talk about Sven and Ole, but you can fill in whichever.
No, in Louisiana, it would be Boudreaux and Thibodeau jokes.
Exactly.
There you
yes.
go.
I mean,
exactly.
Yes.
Right.
And maybe not ice fishing. Maybe not ice fishing.
Right.
Well, Dr. Kane, it was so much fun to have you on. I hope you'll come back and join us.
I would love to come back.
Yeah, Dr. Kwapish was the one who suggested we chat with you, and he would love to have you come back and do an episode with him.
Well, he's Mr. Media. I mean, he's on television.
Yes, he is. Yes, he is. Yeah, we gave him a little bit of a hard time about that.
We miss him terribly.
I think he misses you guys too, but we won't tell Baylor that. Anyway, so lovely to have you on.
Yeah,
thank you so very much. We really appreciate it. And again, come back and be our guest anytime, and we'll come down and see you in Rochester.
Absolutely. All right. Take care, ladies. Thanks for having me.
If you enjoyed this episode, please rate, review, subscribe, and share with a friend. Thanks.